Hello, everyone. Once again, welcome to the session. We have so far four speakers on, and I will start by introducing them. We have Dr. Catriona White on the call. Dr. Catriona is a clinical pharmacologist, a physician, and a principal investigator. She has a BS, an MBCHB, and a PhD from the University of Liverpool, and currently works as a Wellcome Clinical Research Development Fellow based at IDI. Her specialty is in understanding safe and effective use of medicines in populations that are usually excluded from clinical trials, including pregnant women and breastfeeding mothers plus their infants. Her skills range from clinical trials, clinical management of complex and acutely unwell patients, and she also has expertise in pharmacokinetic modeling and public engagement. She has won the British Pharmacological Society Prize for Equity, Diversity, and Inclusion in year 2021. And she's usually, she frequently speaks at career events and mentors junior science. Thank you, and you're welcome, Dr. Catriona. On the forum also today, we have Dr. Miriam Lekker. She's a medical doctor, a research scientist, and she has over 10 years experience in academia and working with organizations. Her research interests in HIV-associated cancers, including Kaposi sarcoma and cervical cancer. She's also a faculty in the clinical pyramidal course, the University of California, San Francisco, and implementation sciences course at Makerere University. She is also a board member of various organizations, including also Reach Out to Mbuya. And she's been a co-founder of AWISH, which is a hub for women in science and in research. Next, we have Dr. Brenner himself. He's a medical doctor by profession. He holds a bachelor's degree in medicine. He's been a global shaper under the World Economic Forum, which is a hub, and Young Emerging Leaders Project Fellow with Leo Africa Institute. He's been a co-founder of and a clinical lead at Mscan Uganda, and he's also a CEO at Kangaroo Plus that makes neonatal jackets. At Mscan, Dr. Imsugwe is responsible and in charge of clinical protocol, documentation, strategy, and he also holds experience in business, research, and community health. Well, we also have Dr. Babra, who is a specialist in infectious diseases and has worked at infectious diseases for a long period of time, since 2004. She's currently the head of research department at the Institute, and she has designed and implemented several observational cohorts at the IDI, and she has participated in a wide number of clinical trials. She has also mentored and supervised several masters and PhD scholars at the Institute. Currently, she's the PI of a COVID-19 cell survey among people living with HIV, and the study is addressing COVID-19 vaccine hesitancy. We also expect Brian to join us. He's also a co-founder of a project called Uganda. He has 15 years implementing, he has spent 15 years implementing projects to do with innovation. And also these projects also aim at scaling digitally inclusive health systems, which are to be built on for IR technologies and business models. So you are all welcome. Today's discussion is based on, we are looking at health innovations in addressing equity and inclusion in the area of health. So I would request my speakers to say hello to the participants as we move on. I'll start with Dr. Catriona White, please.
Good morning, and thank you for the opportunity to take part in this very exciting panel discussion. I think the issues we discussed this morning are key, and we very much look forward to your interaction and participation. Thank you very much.
Welcome, Dr. Catriona. Dr. Miriam Lekker.
Thank you, and hello everyone. It's a really great pleasure to be here to discuss something that is changing more rapidly than any of us could imagine. It's going to be a pleasure to share my experiences, to listen to my fellow panelists, and also to learn and hear from everyone who has chosen to be part of this breakout session. Thank you.
You're welcome, Miriam. Let me also call upon Dr. Himsiwe Prosper to say hello to the participants.
Hello, everyone. I hope it's a good morning. Where are you from? Yes, it's a pleasure to join in Innovation Conference 2021. I'm very glad to share my insights on innovation, and also learn, eager to listen on from this and their questions. Thank you.
Thank you, Dr. Prosper. Lastly, let me call upon Dr. Babra to say hello to the participants.
Sorry, 1 second. Hello, sorry, 1 second. I lost my earpiece. Good morning, everyone. I'm trying to put the video just for a few seconds. Good morning, and you're welcome to the session. Thank you.
You are welcome, Dr. Babra. So to kick off, as I said, we are looking at innovations in terms of addressing health inclusion and equity. We've all heard for a long time that in the health sector, we need to look at these two words that are really important: equity and inclusion, which means that equity, we are looking at ensuring that both healthcare workers and patients that we serve both have what they need to achieve the best out of the services that they are looking for. The doctors have what they need to deliver the information or the treatment to the patients, and also patients have what they need to get in and out of the facilities and get out with what they have gone to get. While inclusion, we also look at both employees and patients voice having to get high quality of care, and also we encourage the presence of diversity as we look at this inclusion. So in today's meeting, from the speakers, I want to know to what extent have we used the technology or the evolving innovations to keep our work going, given the situation that we are in, the situation of COVID pandemic that has led us into continue our services in the business unusual, in the aim that we see that our patients or our clients that we serve continue to engage. So we could give a few experience and probably talk about this in wide. So I will start with Dr. Miriam to let us know, tell us more about how technology has helped us to keep the patients engaged.
Thank you very much, Hope. I'll just interestingly talk about how we went back to the very basic technology, which is the use of the phone, the cell phone, because a lot of our patients, especially in our research studies, could not come to hospital either because transportation had become too expensive or it was a lockdown period, and many of them were on follow-up. So we simply moved back to basic technology, a phone call. So a lot of our work moved from in-person visits when patients were not very sick to talking on the phone. And when they needed referrals, we talked them through the referral process using a phone. And when they got to the facility where they were going, we talked to the clinicians who were seeing them on their cell phones as well. So we really went backwards to that basic technology. And then also we took advantage of like what we're doing right now, conference calling, because we have sites in multiple places throughout the country, but also in other countries in Africa. And in the past, if you were doing something like protocol training, you're just checking up with the sites, you had to go there in person. But during these last 2 years, we have learned and adapted very fast the use of electronic calling using like conference calling facilities. And interestingly, we've been able to train sites to actually start new sites completely. And it's going much better than we had actually hoped. So it was really a use of already existing technology, but making it more, using it more to the capacity that it has, and even probably more. So that has been part of my experience. Thank you.
Okay, thank you, Miriam, for your experience. Getting to Dr. Babra, I know she's having, we saw that she has she's a PI on various studies in IDI. Did you get any issues to do with patient follow-up? How did you employ any tool that you employed during the COVID lockdown that helped your studies and your clients moving during the same time that we had lockdown?
Thank you very much, Hope. So, of course, I wouldn't want to repeat what Miriam said. So even for us, it's been mainly really the phone, because, you know, like, not everybody has a smartphone, so you really have to go back to basic calls, but that still helped us. For one of the study, I remember that we asked patients if they minded if we were doing visit by phone, and I remember that the answer was very positive. They were really in the lockdown, and they were saying at least someone is checking on us. So this is very good. Maybe to add something that has not been said, in my department, particularly the research office, we actually been coming up ourselves with some innovations. For example, we actually moved from physical study binders to electronic study binders because, of course, of access. People could not access their files. And also with limited with people not able to move all the time, there was also a problem with the monitors. So at least these days, monitoring visits can be not totally, but greatly done using an electronic binder, and the monitor doesn't have to be physically on site. Maybe just the other innovation I want to mention is that last year we activated the IDI Research Ethics Committee, was accredited, and we started it, and it's totally virtual. We had already 6 or 7 meetings. We don't sit around together. Presenters don't come around, and we actually even get people presenting from abroad. People who will conduct research in Uganda but are presenting, for example, from Kenya, from the UK. So that virtual format has become very convenient. Thank you.
Thank you, Dr. Babra, for submission. And I think she has really hinted on something that is important, that so far we are conducting our meetings, the research meetings, and including people not from here, and we are able to engage with them via the use of technology, and how research also has evolved to have a submission of our protocols and other things done via the net. Thank you so much. Dr. Catriona, there has been a remarkable disparity in ensuring access to equitable healthcare, especially in the era where we are adopting these new technologies. And so what do you think should be done to inform the advancement of these technologies as to address the key areas of bias and inequality that are already existing, and people have bias already? So what should we do as we introduce the technology and all these new ideas for people to uptake? And what should we consider to reduce the bias and the issue of inequality, the populations that we serve?
So that is an absolutely fantastic question. And I think all over the world, we have experience of how technologies have helped us in our clinical care, in our research, in our networking, and possibly even other aspects of our lives. However, what seems to happen is there's always a marginalized group. And sometimes by bringing in technologies, you just change who that excluded group is. So for example, Dr. Babra and I yesterday had a conversation about high income countries, Italy and the UK, where many technologies have been adapted in COVID, but there have been real challenges faced by the elderly in accessing these. So suddenly the elderly who previously have had really good experience of healthcare are the ones that are marginalized perhaps in favor of the youth. In Uganda, it's going to be different. It's going to be a bias towards those who are technology literate, who have access to a device perhaps, who have access to a power supply and so forth. I think in any part of the world, if you're introducing something new, the first place to start is with the communities. So I think we need to go out into a particular community and actually ask. So do some mapping. Some of this work has already been done. So we know, for example, we talked about basic phones. Dr. Miriam talked about basic Nokia phones. Many people have those. So who has those? What about smartphones? Who has those? How do people want to receive healthcare messaging? Are people able to engage with it? So I think in order to reduce inequity, we have to actually go out into the community and have community engagement right from the very start. And not just community engagement, but I would also think community empowerment and collaboration, bring in community members as key stakeholders alongside innovation projects. So that's one of my thoughts. In terms of how we actually do that, I'm aware the area is vast, and perhaps that's something that we can continue to pick up upon. Thank you.
Thank you, Katrina, for your good submission. And I think that has addressed and hinted on how we can address bias and inequality. So Dr. Prosper, I know you've been involved in innovation of various services, putting them up to help out to the patients that we serve. Can you let us know what you've been doing and probably what you've invented, how it has helped the population or the clients that we have in this area? Thank you.
Thank you. Again, I'm glad to join in. I will agree with the rest of the panelists that COVID came and created, new needs of healthcare. I work with a startup called Mscan Uganda that delivers portable ultrasound devices that can be used to scan pregnant mothers in resource-limited settings. That includes villages, refugee camps, fat-rich areas like islands. So we're already doing some work around that. We had a scan in Kalangala Island, Kalangala district, serving a population of about 80,000 people. And we were actually carrying out scans. So mothers who previously were taking 2 hours to reach the mainland to get an ultrasound were able to actually now receive an ultrasound 3-4 months before their delivery date at the island, and complications that were detected, the mother would be, referred for care by by a qualified health worker. That would be worked on as soon as possible. But I think for me, COVID kind of laid bare the inequities we had, and inequalities we had to access of healthcare. There are long-standing unmet needs that have existed, especially for resource-limited settings, that had to be addressed. So when COVID came, those were exacerbated with the lockdown and everything. So for us, we moved on actually with the restrictions, some of the restrictions that were holding us back, like moving to communities, setting up new IPC, protocols before we could actually visit some of these centers. We had to actually reinvent the way we actually deliver some of the medical outreaches that we do. At Mscan, we're able to develop a new home-based ultrasound service because people are scared of going to hospitals. Hospitals were full with COVID patients. So we reached out to mothers in their own home. So they would book with us, and we actually get a healthcare personnel, a radiographer, who would move with the PPE, the protective personal protective equipment, and be able to do the scan in the comfort of someone's home. So as a company and a startup, we had to reinvent ourselves, both here in urban centers where we recognize the need for care, especially in people's homes, and also the existing healthcare needs that were in communities that are marginalized, like distant islands, refugee camps. Actually, our latest outreach is with Bidibidi refugee camp, where we had the medical outreach there, and we actually noted that mothers, it's the same condition. Mothers cannot either afford the existing ultrasound machines are too bulky that they cannot be maneuvered in a refugee camp, access to electricity, healthcare personnel. So those are things that I think as healthcare innovators, we have to navigate to be able to deliver ultrasound or healthcare in general. So I'll definitely agree with Dr. Catriona that we as healthcare innovators, the responsibility is on us to develop solutions alongside these communities and engage with them right from the inception. Thank you.
Thank you, Prosper. This brings me to the next proper issue that probably have you thought of engaging with other stakeholders, because we know that with the technologies developing, there is already inequalities in communities accessing healthcare services and the other services that we provide. So is there any...
You had a problem, Ivan.
I'm sorry about that. Is there any benefit in engaging the other stakeholders to remove or curb the inequalities that exist? Dr. Babra, you can help us probably throw more light on that. If collaboration with other stakeholders could help us to kind of curb the issue of inequalities as we serve our people.
So yes, I think of course that can help. I think I'd like also to bring back what Catriona said, that what we need to engage first, I think even before other stakeholders, there is the community, because sometimes technology needs either to be adapted or to be understood by the local context before actually you try to use it. I think that we have learned a lot during these couple of years, and I think that it should really be us, the community, and then I think that we should probably involve, let's say, someone like IDI. I think there should be more discussion probably with the Ministry of Health, if some of these innovation can be actually used really to scale up and continue national programs. And then again, probably I would say that innovation that require use of phones, use of internet. I think we should also actually approach the phone companies and work all of us together, because right now, for example, all these innovations that are internet-based are quite expensive. Internet is very expensive in Uganda. And so we are all happy that we can Zoom, we can all do our things remotely, and we can have a virtual conference, we can have a virtual research ethics committee. But truth is that the price on the internet is quite pricey. So there is really a lot to do, I think, and we will also need to move with some people in the corporate world. Thank you.
Thank you, Dr. Babra. Dr. Miriam, can you throw some light on the same? How do you think we can use collaboration with stakeholders to kind of address the issues of inequalities?
Okay, thank you very much, Hope. I think that is a very relevant question. And I'll start off with Barbara's last comment about even things like Zoom meetings. Because if you think about it, even this meeting that we are attending right now is limited to people who are able to afford to pay for the internet and are in a place where there's internet access. There are fellow colleagues who are in more remote parts of the country who would have loved to be part of this discussion, but because of that, they're not able to participate. What I'm trying to get at here is that it's really important for us to find out who is the target audience for whatever it is, a medical device, a medical innovation, or a conference even like this, and find out who is our target audience, and then ask ourselves, are we able to reach them? Are they able to partake of this great innovation that we are coming up with? The other thing is also finding out so in the case of our patients, what do they want? So many times I feel like we come up with these innovations from our perspective and not from the perspective of the people we want to use it on. I have read of a number of scenarios where patients are involved in, first of all, determining even what topics of research are interesting, what kind of medical devices are necessary. So I believe that we are missing out that end. The key people we are developing these innovations for are not the people that are benefiting from it, because we are not asking them for what they need. And then finally, being in a university, we have access to many other colleges within the university. And a lot of the things that we are developing because of technology are really very techy. And so it would be very interesting if we intentionally involve like the departments of IT, people like engineering to come in, listen to what we are trying to make and help us translate those things into actual things. I know there are groups that have done this and it's working amazingly, but I think it should be a more intentional effort. Thank you.
Thank you, Dr. Miriam. Going back to Prosper, probably you've been at the forefront of developing the technologies that are being used, as you've explained to us earlier. So which stakeholders have you probably engaged or used to help you market or spread your innovation? And how helpful have they been?
Yes, thank you very much for that question. I find it a very pertinent question, especially for us, healthcare innovators who are the front line of this movement. So to bring this into perspective, I think it's very important, like Babra shared earlier on, to have, the target communities at the center of your innovation. So I will give an example from the inception of Mscan Uganda. So in 2017, when we were setting out, we actually did a needs assessment with Mubende district, which is the third largest district. So we're assessing why were mothers, in this district. It also had a high maternal mortality rate. It was among the top 5. So we're asking ourselves, where are the gaps? And we had to go and, profile mothers, talk to them, have a conversation with them. What are the challenges that you go through, during pregnancy? Since our focus was ultrasound, we had to ask, where is the nearest place that you're able to get an ultrasound? What is the distance that you have to carry to cover? And how much do you have to pay to actually access an ultrasound? And what we got was very alarming. Mothers had to travel as far as 20 kilometers back and forth to actually get an ultrasound. And we had to bring all this into the innovation and say, what is needed here? So if Mubende, places like Mubende don't have electricity, the big machines cannot be maneuvered in some of these remote areas. We're like, something portable and affordable and accessible is what the people in Murende need. So right from the journey, I think it's very important to bring the major stakeholders who are the beneficiaries. So in the innovation space, we call this a human-centered design. And I think this is something that should be fundamental when it comes to the development of any innovation or any innovation cycle. I would also want to hint on sustainability. How do we ensure that whatever we're developing is sustainable? So so the first step is including the major stakeholders in a human-centered design right from the inception. Two, I think we have to look at who are the partners, who are the people who have the big wings, to be able to scale your innovation, to support you, 1-2 years when you're not, at the site of execution of the innovation. So we reached out to Airtel Uganda. We have now they're able to provide us with data for some of the scans that are done, and midwives cannot, access. They cannot be able to tell which complication it is. They can refer to that case to a radiologist in Kampala, and they're able to get feedback then right there. We're also partnering with Ministry of Health with support from JICA, Uganda. So I think we also need to look at who are these people with the wings to scale, and who have the resource, and who are interested in what you're doing. So whatever you're innovating for, there are people who are definitely interested in your work, but you have to begin, and along the journey as you're going, people will definitely come and dig into what you're doing. I also want to raise another question. I think we can have a debate on, which is financing. How can we develop platforms for sustainable financing for healthcare innovation that are addressing equity and inclusion? And I mean for not just mothers, but for people in refugee camps. I think recently there is a talk on LGBT, which is a bit very controversial in my country. But they also have healthcare needs. So it is the diversity is quite there, and we need to think of how can we continue supporting the ecosystem of healthcare innovation, right from inception to stakeholder engagement and to financing. Thank you.
Thank you very much, Prosper, for that quite elaborative explanation. And you bring in a very important issue of financing. I don't know if the question was to be addressed to the fellow speakers, or if it is something to think about still. But if anyone has something to respond, something to talk about financing, and yeah, we can talk about it. So when I get back to Dr. Catriona, any experience with engaging stakeholders in a way of helping us to widen or to improve, or in the process of implementing what technologies that we've developed? Do you have an example of that you can share with us? Meanwhile, we can keep your questions going through the chat. We shall respond to them as we go on.
So thank you for the question. And Prosper, I really liked the way you brought in many key points during that brief summary of your work and the engagement that it requires and all the issues. The example I have, it's not my own research, but the best example I've come across in the literature is that in South Africa, there's an app called Mom Connect. So it's an app for gathering information about pregnant women, but it's also got a sort of two-way interactive process whereby expectant mothers can submit questions, they can flag up any medication safety events and so forth. And they've actually achieved, I think, 63% coverage, so that over the last couple of years, around 63% of all pregnancies across South Africa, the women have registered with this app. And I think the thing that was key about it was they obviously did some pilot work to prove that it was a feasible and beneficial thing. So I think that's something that we need to remember with innovation. It's very easy to almost jump ahead of ourselves and say, this looks like it should bring benefit, therefore we're going to start using it and hope people take it up and hope it achieves benefit. But we actually do need to do research into that. And I'm sure this will be coming up in many parts of the conference. So if we have some pilot data that show that something is feasible, potentially the costs are different, but it actually might save money at the point of healthcare facility or transport, and it's achievable, it may benefit health, then the stakeholders are going to be interested. So with this Mom Connect platform in South Africa, the principal investigator and the Minister of Health, they almost did a joint launch, and they kind of moved around the country doing sensitization events. So it was like Ministry of Health in partnership with the researchers. And there was quite considerable subsidy from the mobile phone companies, because I believe the running costs were something like $1 million a year. So not insignificant. But by having the pilot data, and then doing this almost partnership between investigators, Ministry of Health, mobile phone companies from the outset, it's achieved something that I find is quite outstanding. And there are papers in the literature that you can refer to as that. So I think it's a good exemplar that we can learn from. I don't know how achievable that is for some of our smaller things we're trying to start up in Uganda, but it's an example.
Thank you, Katrina, for that. Yes, it's a good example. It's just something to think about and see how you've said the smaller things are being implemented but not going, but it's something that we can think about as well and probably build up. And also takes me back to what Prosper asked us about financing and how can we develop a sustainable, way of financing. Does any of the speakers have something to comment on financing? Or Prosper's concern, or talk about how we can sustain, or ways that we can try to finance and create sustainability of the innovations that are being created. Dr. Babra, any, or Katrina, any? Please, you can come in.
I was just very quickly going to say, I think evidence is key. Because if we do want people to invest, particularly if we want government and ministry to invest, we have to be able to present a case that it's worth investing in. So I think we do have to have that evidence. I don't know, Barbara, you perhaps have more to say on this.
Well, yes, I agree with you that you need some preliminary data, you need some evidence. The other thing is I was just thinking, at simple things like running a virtual meeting, or again, running a virtual committee. These are actually innovations that use technology, which, I think eventually if you cost them, you may be saving money and time. If you think about people moving up and down, not using their fuel, not using their time. If you think, yes, it's true, the internet is expensive, but fuel in Uganda is crazily expensive either. Using a room. So some of these, substituting some of these, so using technology does not necessarily mean that you're going to spend more money. So I think that is another piece that someone has to look into. Of course, if you have a new device, that is going to cost you money. But there are things where we are now use technology in a smart way that may actually not require no financing. Over.
Thank you, Dr. Babra and Katrina, for the suggestions or the insights on how we can sustain and probably trap more funding and sustain the innovation. Swinging you back to the current epidemic that is ongoing, I would like to know what you speakers think about this pandemic. What has it taught us about health inclusion and equity? To you, Dr. Miriam, what do you think? What lessons do you think we've learned during this COVID-19 about health inclusion and equity.
Thank you very much, Hope. The first thing that I believe we've all learned from this pandemic is that even when things seem to be happening, moving very smoothly, we should not be comfortable because we never know when things are going to change and force us to change along with them. The second thing, what I've learned about equity and inclusion in this pandemic is that if we're not conscious and don't make it a conscious effort to reduce or to bridge the gaps between the wealthier people who have a bit more and the people living who have less, then when you have a pandemic like this, the gap widens. A simple example is just look at the medical system now. During COVID, there was a time when, especially during our second peak in June and July, the people who were not, there was a lot of COVID testing available, but they were accessible to a certain class of society. I mean, you could call and have people come and do your COVID testing at home. It wasn't free, minimum about 70,000 shillings. What proportion of Ugandans were able to afford that? So even if technology had advanced so much that you could call